box as well. Could you hear me, sir? Or I was lost.
Yes, sir. Vijay sir,
Yeah.
you can start the session. I'm
Yeah.
sharing the screen.
Okay. Fine. Fine. Uh, 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 Good morning and hello everyone. A very warm welcome to 2021. We have seen a very tough time in 2020, and here we are with lots of hope and beginning the new year with after fighting against the COVID. I'm very pleased to welcome everybody, the audience, the participants, and to this first and foremost academic activity of hetero healthcare uh, on lupus. In fact, hetero as an organization has been in the forefront in managing various virological diseases in pandemic, HIV and AIDS. Then we have seen the bird flu, the avian flu, as well as now we are one of the leading companies in managing COVID as well. However, having a very strong portfolio of more than 300 drugs as well. A couple of years back, we entered into rheumatology segment, which is one of the most complex subjects in medical science. In rheumatology itself, there is a big list of autoimmune disease, which indeed pose challenges right from diagnosis to management. Out of which, there's one more very interesting topic called lupus. The disease called lupus, which is a wide topic in itself, which takes toll on the patient, whether it is peripheral or whether it's systemic complications. So understanding in this topic is of utmost important as well. Uh, so we take this opportunity on the first Sunday of 2021 to begin with our academic activities as we do consistently on various subjects. So lupus or connective tissue disease, what a family physician should know. To talk on this, we have with an extremely dynamic speaker, Dr. Nilesh Nolka, who is a consultant rheumatologist in Wockard Hospital, Mira Road, Nama Hospital, Kandivali, and Critical Hospital, and he is attached to this all uh, esteemed hospitals. He completed his MD in General Medicine from King Edward Memorial Hospital, Mumbai, India. He completed his DM in rheumatology from King George Medical University, Lucknow, India. Most importantly, what's more, the first one with DM in state of Maharashtra. Most strikingly, we can see he stood first and passed his DM rheumatology with honors. That's distinction, and he's the only one to get this honors in 16 years of history of doctorate level. That's indeed a great achievement. Fellowship in rheumatology in India. He has more than 10 peer-reviewed publication in national and international journals. So talk on this lupus and connective tissue disease. Over to you, Dr. Nilesh, sir.
Hi, sorry. Yeah, I was muted. Okay, thanks, Vijay. I'm just sharing my presentation. So, yeah. Is the presentation visible?
Yes, sir. Yes,
Yeah,
sir.
yeah, thank you. Happy New Year, everyone. A very good morning. A very big thanks to everyone who has joined on a Sunday morning. It's always difficult to join webinars on Sunday, at least from my end. And it's very heartening to see such large number of people participating. And I hope I make it worthwhile. I'll not make it very long. I'll make it short and sweet. The whole point of this talk was to just apprise the physicians and GPs of what is exactly lupus or a connective tissue disease. And sometimes even best of rheumatologists falter in these kind of diseases. So it's this is just a primer. I'm going to give you a lot of examples on what should happen in real life. It's next to impossible to talk about lupus or connective tissue disease in one single go, but I'll make it very, very practical. And if you have heard me before, I usually try to go down to level of diagnosis which GPs can make, and also in what part of treatment protocols can GPs help. Rheumatologists being a rare specialty and many few rheumatologists around, I usually also feel that even if internists can handle a bit of rheumatology in at least peripheral areas, it is a great help for many patients out there in the periphery where rheumatologists are not readily available. So I'll do a lot of things which will be simple, which will be complex, but some things you should take out and that should help you in your daily practice. Sorry, Mr. Vijay, I think there is some request for people to have a recording so that we can share it later. So if you can arrange it from your end, that will be great.
Yes, sir. We are doing that, sir. We are doing that, sir.
That's fine. Yeah. So lupus and connective tissue disease, what family physicians should know. Again, I have named it lupus and connective tissue disease because lupus is one of the commonest connective tissue diseases we know of. But as the name suggests, I'll be not only talking of lupus, but I'll try to focus on both parts. And sometimes they are brothers and sisters of each other. You should just know how to diagnose it, and later we can actually decide on treatment depending on the clinical manifestations. So I'll focus on a connective tissue disease group as a whole. Yeah. So the aim will be a primer with a lot of real life scenarios, when to and when not to suspect CTDs, learning from mistakes, what and how to do an ANA test, what are the best practices, how to treat and what GPs can do. It will be very difficult for me to go on a tangent on how to treat in very detail, but I will put out certain pointers if there is enough time at the end. So we'll start with the first slide. So connective tissue disease are defined as group of acquired diseases resulting from persistent immune mediated inflammation. Now, please understand that the word connective tissue diseases is also used for diseases like Marfan syndromes, Ehlers-Danlos syndrome. They are non-inflammatory connective tissue diseases. We are obviously restricting ourselves to inflammatory diseases, which are under the purview of rheumatology. We do sometimes see non-inflammatory rheumatic diseases, but sometimes they are not directly into rheumatology domain. So the most common connective tissue diseases are SLE, that is lupus, dermatomyositis or polymyositis, that is idiopathic inflammatory myositis, or systemic sclerosis or Sjogren's syndromes. Sometimes we use the word undifferentiated when it is not fitting into anything. And sometimes there is overlap syndrome called mixed connective tissue disease. Though many people don't use vasculitis when they don't mean vasculitis when they are using the word connective tissue diseases like ANCA vasculitis or polyarteritis nodosa. Church-Strauss syndrome and Wegener's are old names. We usually call them ANCA vasculitis or some newer names like EGPA or GPA. So for Church-Strauss, we use eosinophilic granulomatosis with polyanginitis, and for Wegener's, we use the names known as GPA, that is granulomatosis with polyanginitis. We don't use the old names because I think Church-Strauss and Wegener's were from Nazi era, and we are avoiding those terminology. The same way we use reactive arthritis for writer's disease now. The point is we are going to talk a bit on vasculitis, but I will not go too deep into it. I'll give you some examples, but there can be a lot of overlap between many things. So do understand that many connective tissue disease can have vasculitis as a part of it. For example, SLE can have vasculitis as a part of it, but they are not pure vasculitic diseases. Pure vasculitic diseases are polyarteritis nodosa and ANCA vasculitis and something like Behçet's disease, which are classified as vasculitis, or Takayasu's arthritis and things like that. So we'll stick to connective tissue diseases. But at some point, definitely vasculitis features will also come into the differentials because many things appear quite similar in rheumatology. And sometimes you have to pick out a lot of clues to differentiate between the diseases. So CTDs, though technically rheumatoid arthritis is also a CTD, but it is not given that importance when you are using the word CTD, because though rheumatoid arthritis is a multi-system disease, it usually restricts itself to joint, and the systemic symptoms are in the form of fever, fatigue, weight loss, and sometimes lung involvement is very common. You don't see other systemic symptoms. In other CTDs like lupus, Sjogren's, sclerosis, you see multi-system involvement, and that is why we restrict the word CTD to these kind of diseases rather than RA as such. So obviously we'll not be talking too much on RA also. So very funny diseases, huge number of varied presentations. The biggest problem is the way textbooks show what the connective tissue diseases are. So if you remember a classic example of how lupus is depicted, this is a newer classification criteria, but you see it is something like what we used to remember during our MD days, or sometimes even during your MBBS days. You will have very rote learned the criterias. So there was a mnemonic for it known as SOAP Brain MD. I don't know, everybody had a different mnemonic for SLE criterias, where you had a malar rash, you had a discoid rash, then you had myositis, then you had neurological involvement, then you had renal involvement, then you had immunological criteria. And we used to rote learn those criterias, and we used to think that if you get 4 out of those 11 criterias, we have lupus on hand. But it's a big problem to do that, because do understand that there is no criteria in rheumatology which is diagnostic criteria. So if you start using criterias to make a diagnosis of any disease, and try to fit in the criterias, you will make lupus of almost every patient with systemic diseases. That is the biggest problem of these criterias. You have to fit in these criterias. Generally you have to get a feel that the patient has something autoimmune, then only, and only when you're sure that this is not being caused by something more generally explainable, you have to start thinking connective tissue disease. Because please understand that lupus is not a common disease. You can't start making lupuses with hair loss and ANA positivity, because hair loss is very common and ANA positive in normal person is very common. So you can't fit two common diseases and or symptoms and make a rare diagnosis. So many symptoms you see in these domains, clinical domains, like an alopecia, which is non-scarring, or oral ulcers, or even diffuse rashes, can be seen very commonly. Even arthritis can be seen, arthritis or arthralgias can be misinterpreted, because many people feel that even if you have some inflammation, it is rheumatoid or it is something autoimmune, when it might be just osteoarthritis. It's very difficult to diagnose neurological diseases without a right context. You can't have just an seizure and say that the patient is SLE, because there are many other causes of seizures which you need to rule out. Obviously, when you have multiple things put together, then you should start thinking CTD, and that will be the crux of how I go about these things. So what I'm trying to say, very few people have a classic textbook picture. So you will, I usually tell patients that only 30% of lupus patients actually have a classic butterfly rash. It's a very textbook picture, but almost 70% of lupus patients I see either don't have a rash, or they have such subtle rashes that you cannot make anything out of it, and they look very non-specific. So only 30% of patients of all CTDs have classic textbook feature. You should have a high degree of suspicion to rule in and rule out. Now, it's very easy to make a diagnosis of CTD, but you should stand your ground if there is not enough clues to make a diagnosis of CTD, and which I do. I tell people, don't be in a hurry to give steroids. Don't be in a hurry to say that it is CTD unless there is something life threatening. Wait for everything to come. Wait for all the clues to fit, and then only. It's like a picture. You have to fit all the clues together, then commit to a diagnosis rather than being too hasty in non-urgent cases. And a rheumatologist cannot be a good one without being a good internist. I always say, and there are many clinicians around me, many of those who are listening, they are brilliant in picking up clues. In fact, in last 3 days, I have had 2 or 3 clinicians actually calling me with such brilliant diagnosis, that I am aware that now people are aware of these diseases. But I do also see people who are not picking up these clues, and my role here will be to make you aware of how to pick these things. But you have to be a good internist first. If you have got a patient with fever, you have to rule out your dengues, you have to rule out your malarias, you have to rule out your abscesses, you have to see for UTIs. Even if the patient has a background connective tissue disease and they get fever, you have to rule out this. Even if they are suspicions of CTD, you still have to rule out some infections. But but do it thoroughly. For example, if you see pus cells in urine, do understand that that can be due to infection, but do understand that it can be due to glomerulonephritis. So you should know the differentials for each and everything. Then only you can become a good rheumatologist, because most of the times when I get a call for seeing patients for connective tissue disease, especially those who are admitted, they turn out to have either infections or non-rheumatological. Just because there was an ANA positive or something, everybody starts thinking of autoimmune diseases, but it doesn't work like that way, and I'll come to that. As I said, there is no clear diagnostic criteria. All the criterias are classification. So if you see the lupus criteria, they are meant for getting patients into trials, so that you don't get non-lupus patients into trials. So they are giving you a scoring system where you have 10 scores, and you need some criteria. You need at least an ANA positive, you need an at least an some clinical criteria and some immunological domains to be absolutely sure, okay, this is lupus. But again, you can't take it everything given in this classification criteria to the point, because sometimes you will get patients who are not fitting the complete criteria, but they are still lupus. They will not have the rash, they will have nothing, but they have a strong dsDNA, they will have some myositis, they will have some low complements. So you have to be very sure that you take a clinical call. You can use the criteria to understand the symptomatology, but do understand that many things have overlaps. For example, delirium, psychosis, seizures can be due to many things. It can be due to meningitis. Your pleural effusions can be due to TB. Your leukopenia, thrombocytopenia can be due to dengue or can be due to malaria. Your urine proteins can be due to some active kidney injury. But yes, if you have multiple things going on and not explained by anything else, once you have thoroughly ruled out anything else, your autoantibodies are strongly favoring, then obviously you make a diagnosis. You never make a diagnosis of CTD based on one single test or one single event. As such, you have to, as in medicine, in many things in medicine, you have to see the complete picture. And even best of tests in rheumatology are non-confirmatory and can mislead. I'll give you a lot of examples where the patients had gout, but they had RA factor positive. I have examples where the patients have anti-scleroderma antibodies positive with no evidence of scleroderma. And I have patients with Rho antibodies positive and multiple symptoms, but there is nothing which is confirmatory of Sjogren syndrome. And they are given steroids for no reason. They just have fibromyalgia. So please be very wary of over diagnosing patients, because you are going to give them immunosuppressions or immunomodulators, or you are going to give them a label which probably is not required in those cases. So you have to put many pieces of puzzle together, and then only make that particular diagnosis. And I'll explain this concept as I go along. uh, I thought that I should start with how to do an ANA test, because once you know that, it might be easier to be receptive of the examples I'll give in the near future. Many people are very good at ordering ANA test, but I see still a lot of mistakes being done when an ANA test is ordered. And it's very, very difficult to convince patients to repeat an expensive investigation when you have already done once. And it takes a lot of time to explain them everything again. So you have to understand that you can do ANA by ELISA and ANA by immunofluorescence. Please do understand that ANA by ELISA I'm sorry for fluctuating with the slides. ANA by ELISA is a very unoptimized method. There are a lot of problems with it. You have a well where you are putting a lot of antibodies, which are anti-nuclear antibodies, and then you are expecting that those will react with the blood sera and something will come positive. Now the problem is the ELISA are not standardized, and sometimes, for example, in that well, somebody hasn't put a Rho antibody, and the patient has only Rho antibodies. The ANA by ELISA will come out to be negative. More often than not, I see many false positives with ELISA, because ELISA based tests are very notoriously false positives if they are not done rightly, because even a small mistake can lead to a very strong positive test. You have to understand that the wells are very small, and the pipetting should be very perfect for that. So for many reasons, ELISA is not reliable unless and until the patient is frank lupus, and I don't nearly need to repeat ANAs. and I have something strongly positive on the blood test, I will always order an ANA by IFA. Please make it a habit to write ANA by IFA. Please do that, because when you just write ANA, most lab will do things on their own. Many good labs do ANA by IFA only, or they will ask the clinician. But when you are writing, please always write ANA by IFA. Please try to get rid of ANA by ELISA. I think it should be totally banned test, because it creates so much confusion in daily practice, and sometimes it misleads the clinicians dramatically. So when you do an ELISA test, you just have a well, you put patient sera, you have a reaction, and you get either a positive test or negative test. But when you do an ANA by IFA, there are certain advantages. First of all, you are using a slide which contains a cell. So a cell will have a nucleus. It will have all possible anti-nuclear antibodies. You don't have to separately form an ELISA kit for it, because a cell line already has all the nucleus and all the antibodies. Now, on top of that, if you give patient sera, it will react to those nuclear antibodies, and then you attach immunofluorescence to it. And that is how this immunofluorescence looks, the slide I am pointing to. And that is why it is a more confirmatory test. On top of it, it can give you an idea about the intensity. So whenever you are seeing an ANA test, understand that there are two things at play. When you are writing ANA by IFA, they do it at a fixed dilution of 1 is to 100. They don't do it as serial dilution. They do it as dilution of 1 is to 100, and then they see the intensity under the microscope. They have a standard, which is 4 plus. So these all slides are 4 plus. And if it is slightly lighter than that, it will be set 3 plus. If it's slightly lighter than that, it is set 2 plus. It is slightly lighter than that, it is 1 plus. Now, 1 plus ANA correlates to 1 is to 100 dilution or more. 2 plus ANA correlates with 1 is to 3 dilution or more. 3 plus ANA correlates with 1 is to 1000 dilution more, or very strong positive ANA correlates with very high dilutions. Now you will say, why don't you do dilution? There is a method of dilution also available, where you can write ANA by IFA with dilution, because if you get higher titer, it becomes more important in that patient's history. But do understand that when you are going to do a test in dilution, you need multiple examinations and multiple wells for that patient, and that will increase the cost of the patient. So ANA by dilution can become very costly. So what we use is a surrogate marker. We just do it at fixed dilution. So when you write ANA by IFA, it is done at fixed dilution. We see the intensity of immunofluorescence, and we accordingly give it 1 plus, 2 plus, 3 plus, 4 plus. Now do understand that this is operator dependent. So sometimes 2 plus, maybe 3 plus, 3 plus, maybe 4 plus, or what is reported as 4 plus, maybe actually 3 plus for somebody else. But doesn't matter. You should never interpret ANA on its own. It should be always along with a clear-cut clinical context. So many people harp on ki, "Arey, ANA is 3 plus, arey, ANA is 4 plus." I always say ki, it's fine. It's a strong positive ANA. I do understand. But I always see what is the context behind it. We have had problems where the patient had ANA 4 plus and homogeneous, which is sometimes very specific for lupus, but the patient had nothing. So you have to be very sure of the clinical context. Otherwise, it becomes very, very difficult. And do understand that ELISAs are very useless and creates a lot of confusion. Neither a positive test is very useful, or neither a negative test is very useful in clear context. Do understand that when you're using ANA by IFA, serial dilutions are not done. The intensity is operator dependent. But if you are a good clinician, and if you know what to look for, and if you know when to suspect and when not to suspect, ANA just becomes a part of your process. It is not a confirmatory test, as I will keep on repeating again and again to the point that you will be bored. But please understand that ANA is not a positive test. At least 70% of ANA positive in my clinics turn out to be a different rheumatic disease. So it's not bad when non-specialist order ANA, because at least it initiates rheumatology referral and the patient gets a proper diagnosis. For example, sometimes I get ANA positive patients who have gout. Sometimes I get ANA positive patients who are ultimately diagnosed to have psoriatic arthritis. Sometimes I get ANA positive patients who are diagnosed to have malignancies. So you have to be very thorough clinicians and don't judge ANA on its own. But yes, there are certain patterns which are helpful. A homogeneous or rim pattern can be very specific for SLE, but if you don't have the right context, it can be non-specific also. The most non-specific pattern is speckled because it can be seen in almost all CTDs, and more often than not, you will always get speckled pattern in most non-specific ANS. So a speckled is the most common pattern. I don't go into too much detail of other patterns. You will get centromere pattern in sometimes limited scleroderma, but sometimes it can be non-specific. And sometimes the nucleolar patterns are very common in scleroderma patients. So these 3 or 4 patterns are fine. But if you go and see that report of some labs like Metropolis or maybe SRL, you will be confused with this whole table. It is extremely confusing, and please don't follow this table. Don't try to match your pattern with these things. You have to be very sure of what each disease has, because this is not very specific, and this does not always follow what you think. And many patients have ANA with some vague patterns, and may have a severe disease, and sometimes they have an ANA with a classic patterns and may don't have the disease. So don't be too behind the pattern or intensity. You should give it importance, but not undue importance. Definitely, if you have a homogeneous pattern with many other features, I will give it importance, especially if it is 3 plus 4 plus or the dilution is very high, or speckled, which is very strongly speckled 3 plus 4 plus. But I have to have the right context. So unless and until that is there, it's very difficult to say that patient has CTD. Only thing which a negative ANA may rule out is, it definitely rules out SLE, it definitely rules out MCTD, but it should be repeatedly negative. I will come to what is repeatedly negative. The problem with one single ANA report is it can sometimes be false negative. So I have had patients where we have had a very high degree of suspicion. The first ANA was reported to be negative, and the next ANA came 4 plus homogeneous. But if you have 2 or 3 negative reports, the way we do in ELISA, we don't HIV ELISA, we don't say that one ELISA negative is definitely negative HIV. We do 2 ELISAs. Similarly, when you have a positive HIV ELISA, you need to do a second ELISA by another method to say that it is definitely HIV. Similarly, in lupus, one negative ANA, small degree of suspicion, definitely rules out SLE. But if you have a high degree of suspicion, I might repeat an ANA again. But in most cases, a negative ANA only rules out MCTD and SLE. Please understand, it doesn't rule out many other things. It doesn't rule out myositis. It doesn't clearly rule out Sjogren's syndrome. It doesn't clearly rule out other rheumatic diseases like vasculitis. So you can have a negative ANA and you can still have a very severe rheumatic disease. So please do not forget that only and only pure lupus patients and pure MCTD patients are very unlikely to have negative ANA. There was a concept of ANA negative lupus, but now with newer methods, we don't think ANA negative lupus is an entity, because more often than not, they have some other hematological diseases. So you also have this ANA blot, this fancy looking blot where you have 17 antibodies. But if you ask me, the only ones which are slightly important is SMRNP. If you have just SMRNP, it's a combined antibody. It's usually MCTD. But suppose if you have multiple antibodies, so all lupus patients usually have at least 3 or 4 antibodies. If you give me a patient with ANA positivity and only one single antibody like a histone, like a nucleosome, it's very unlikely that that will turn out to be lupus. Usually lupus has multiple autoantibodies, at least 3 or 4 antibodies coming positive. MCTD usually will have very strong positive SMRNP, but the SM will be negative. Please understand that pure SM positivity is usually seen in lupus. But if you have just SMRNP or something we known as U1RNP, that is usually MCTD. But in lupus, you can get SMRNP and SM both positive, because RNP also has an SM component. In lupus, you will get Rho, SSA, you will get ribosomal, you get histones, you get nucleosomes, you get multiple autoantibodies positive. Now in this, I feel the AMA is not useful, because AMA sometimes is used for biliary cirrhosis, and most of the times the AMAs I get positive have no disease. Many other variants like PCNA is not useful. It is usually a very non-specific antibody. I recently saw a patient with SCL70 antibody positive, and he had an entirely different disease and absolutely no evidence of scleroderma. And I don't think he's going to develop scleroderma. Uh, the problem with SSA and Rho antibody positive as an isolated phenomenon is they can be seen in multiple non-specific events. So again, single antibody positivity without any clear history is very difficult to interpret, especially if there are Rho antibody positive. Yes, if there is pure SMRNP positivity with clear-cut arthritis or Raynaud's or clear-cut puffy hands, I will make it MCTD. But you understand that I'm looking for a puffy hands or Raynaud's to make a diagnosis of mixed connective tissue disease. Otherwise, many antibodies in this profile are not useful. We do this profile because it is very cheap to do it, because if you start doing the separate ELISA for main antibodies, so in this profile the main antibodies are Mi2, SMRNP, SM, SSA, SSB, SCL70, Jo1, and possibly centromere antibodies. So maybe 7 or 8 antibodies are main antibodies. If we do a separate ELISA for each antibody, the cost triples. So I will explain you. So when you do an ANA test, always understand the context. It's a test with almost 30% false positivity. What I mean that almost 30% with ANA test do not have the connective tissue disease, or in fact they are normal. So almost 20% of normal people can have a weak positive ANA. If your pre-test probability is not high, please understand PSM was a very boring subject in our MBBS days, at least for me. But please understand that if your pre-test probability is low and you have a test with high false positivity rate, the chances of that test being positive with a disease you are suspecting and that disease coming out to be true is very unlikely. So if your pre-test probability is not high, your positive ANA will only mislead you. Always order ANA by IFA, because ANA by ELISA has lot of issues. Be sure of what you do if it's positive or negative. And negative ANA does not rule out rheumatic disease or even CTD. It just rules out lupus or MCTD if repeatedly negative. I have already explained that concept. Example of CTD with negative ANA, myositis. You can say that pure vasculitis are not technically CTD, but some people do consider it CTD, so you cannot rule out vasculitis. You can have rheumatoid arthritis, which have negative ANN, and sometimes ROLA antibodies are cytoplasmic antibodies. They go in and out of the nucleus. So the ANA test may come negative, and the clinicians may report it as, the pathologist may report as cytoplasm positive. Do understand that the Jo1 antibody, that is the myositis antibody, and Rho antibody can be cytoplasm positive ANA. Usually most ANA who are reported to have cytoplasm positive are non-specific, but if you have the right context, you have to suspect myositis in that. Do understand that this picture which you are showing, that only the nucleus is flaring up. There is a cell surrounding it and the cytoplasm is coming negative. If you see the surrounding picture, I don't know how visible it is. There is a cytoplasm seen around the circles that is negative in this positive ANA, which is 4 plus. So I don't have a cytoplasm positive site, but do understand that the Jo1 antibody and Rho antibody can come positive on a blot even with a negative ANA. So if I am suspecting myositis, I will not stop with a negative ANA. I will do an ANA blot also. But if I am suspecting lupus, I will stop with a negative ANA, because I think, and sometimes there is an overlap. So sometimes I will do both because I'm not sure what is causing what. So you have to be very sure what you're ordering and why you're ordering. As I've said, homogeneous pattern helps. Speckled is very non-specific, not useful alone. Intensity or dilution, if dilution is high, means if it is 1 is to 200, 300, 600, or the intensity is 3 plus 4 plus, definitely you should look deeper. But just because ANA is negative or ANA is positive should not alone be a criteria of ruling or ruling out the disease. You should be sure what is the clinical picture. There are many rheumatic diseases where are very severe, where the ANA is negative. For example, ANCA vasculitis, for example, rheumatoid arthritis, for example, myositis. So ANA blot or profile is also known as ENA blot or profile in some labs. Remember, when you use the word blot, it's a single line assay, as we have seen in that photograph. but it is less costly because you just have a small amount of thing put on a strip, and that strip is put in a machine, reacted to sera, everything done in one go. But if you do a ANA profile, what they do is they do a separate ELISA for each of 7 to 8 antibodies. So in a blot, you get 17 antigen, but more important are 7 to 8 antigen. When you do a profile, you may get 7 to 8 antigens ka ELISA, which is slightly more specific, but it is very costly. I don't remember doing profiles very easily. I usually am happy with blot because I'm always seeing the clinical context. So be very sure what you're writing, because the whole profile can cost 7 to 8,000 rupees, and even the blot can cost almost 3,000 rupees. You should be sure of what you're ordering. Even profile might give the same answer which the blot may have given. You may get bystander antibodies, especially the Rho antibodies are very notoriously positive in many patients. Usually lupus will have multiple antibodies, very unlikely to have one positive test. Do understand that the PCNA antibody, the AMA antibody, the KU antibody in that profile, if they are alone positive, usually it is very non-specific. Anti-SM and anti-DSGN are very lupus specific, but never interpret anti-DSGN in blot. So if you give me a blot where the DSDNA is negative, but there are multiple antibodies, I will still confirm the DSDNA by ELISA, because blot pe jo DSDNA ka antigen hai, it is very fragile because it opens up and it becomes a single stranded DNA. So on a blot, I will not usually interpret the DNA part of that well. So if I'm strongly suspecting lupus, I will order ANA, I will order an ANA blot, and I will order dsDNA by ELISA, and I will do complement level. Do understand that dsDNA quantitative levels are not done in many labs. For example, Suburban doesn't do it. It is a semi-quantitative ELISA, which is again difficult to interpret. It's usually done in Metropolis, SRL. I think Lalpat does it semi-quantitatively. So usually I will always ask to get it done from some certain labs, especially because when you get me a semi-quantitative result, it is either positive or negative. It becomes very difficult to interpret that because it's a very notoriously notoriously false positive test. So you have to be very sure. So I'll usually ask for quantitative titers from a lab which does it. And that is why it's very important to know which lab does it with which method. And sometimes I do get calls, sir, ANA blot nahi ho raha hai, ENA blot ho raha hai. So you have to write all names possible, or tell them to do it from a specific lab, or get used to one particular lab rather than changing labs. SSA and Rho antibody in a blot can be seen in many people with no clear significance, which is very important to note, because I have seen patients with seizures and Rho positivity being made as Sjogren syndrome when there is nothing much as such. And Rho antibodies are so strongly positive in many patients with non-specific diseases, it becomes very, very difficult to interpret. Some people might say that everything is autoimmune, but I don't believe into that concept. Many diseases have no clear explanation. Just because they have Rho antibody, you can't make them an autoimmune disease and subject them to intense immunosuppression. For example, a seizure patient with Rho positivity just needs proper workup and needs anti-epileptic therapy. They don't really need immunosuppression without having any other features. So be very sure of what you are trying to do with the tests. So how to diagnose CTD? Not easy, but not that difficult. Listening and history becomes the most important things. However cliche may sound in this era of investigations, any new onset systemic symptoms with unexplained symptoms can be CTD. Anything new, I'm happy to see. Anything very chronic, I am usually put off by that. More the clues, better is it. I never just harp on only arthralgias. You need to have many things to make a diagnosis of CTD. Look for some inflammation or some ancillary evidence. Don't harp on only ESR and CRPs. You can have good evidence even with normal ESR and CRPs. Remember that lupus does not have very high ESR and very high CRPs, because lupus does not have much hyperglobulinemia, and lupus does not lead to a lot of CRP elevations unless and until they have arthritis or pleuritis. So you can have lupus with normal inflammatory markers. You have to look for other evidence. There will be many other clues. Usually a diagnosis is evident even before testing. So before even I send the patient for test, I write on paper, this is unlikely to be lupus, but we are doing the test. I also tell the patient कि ये शायद normal आएगा, but आपकी मन की शांति के लिए आप कर लो. You do it for your own relief. You should be sure why you are ordering it. Any youngish female, I have written it less than 50, 60, but anybody who is less than that, who has funny symptoms, unusual systemic complaint, you have ruled out the common things, always think CTD. Usually CTD being starting at after 60 is very, very uncommon. It's very difficult to say, except RA especially. It's very uncommon to see patients above 60 developing lupus as a new phenomenon. I have seen patients, but it's very uncommon. So usually if you tell me a patient above 60, 65, 70 developing systemic symptoms, it may be still vasculitis, because vasculitis can affect people above 60, 70s very commonly, especially giant cell arteritis and ANCA vasculitis. But lupus is uncommon. Sjogren's is usually uncommon after 65, 70. But definitely you should look at all angles. Obviously, malignancy becomes a very important differential at that age in a patient with multisystemic complaint. So if you bring me a patient with 65 who is not being diagnosed, my one eye will always be on cancer or ruling out cancer, and I will be more inclined to do PET CTs in that patients, even if I'm sure there is some underlying CTD. And obviously, you have to always rule out infections as a differential. Always rule out common things. When you hear neighing, expect a horse. You can't expect a donkey. Common things common. In India, if you have fever, systemic complaints, you have to rule out infections, you have to rule out TBs, you have to be very sure. But yes, once your malaria is negative, once your dengue is negative, don't try to explain your leukopenias, thrombocytopenias, thrombocytosis with infections. Do your blood cultures, do your urine cultures. If the urine is still showing pulse cells, the cultures are negative, think of alternative etiologies. Think whether the patient has something additional to think CTD. Always re-question your diagnosis or re-challenge your diagnosis when you're not sure that the things are going into right track, but know when you have to move to the next step rather than creating the same loop. I have seen patients with leukopenia, thrombocytopenia for 4 months, clearly having lupus-like features, who have been labeled as dengue, malaria, chronic dengue, double typhoid, and being treated with multiple antibiotics, and the patient coming to us in a much worse status when they should have been picked up early. Whole body pain and stiffness for many years, and if the patient says yes to every symptom, is a massive put off for me. It is most likely fibromyalgia, but again, I'm not making it a general statement, but usually if a patient enters a clinic and saying कि सर मुझे 10 साल से पेन है, अभी थोड़ा बढ़ गया है, but there is no other symptom, I usually take it with a pinch of salt, and I usually am inclined to not do too much in those patients unless and until I see something majorly clinically. It's very important to ask the stiffness in the morning. I have never seen a patient with joint pain say that they don't have early morning stiffness. Be very specific and ask how bad is the stiffness. It should be worse. It should make them debilitated. It should be really new and unusually difficult to do things in early morning. But remember that some patients with OA can also have 30 to 45 minutes stiffness, and OA is a much common disease. So by sheer numbers, OA will surpass lupus or arthritis or rheumatoid arthritis patients in the patients presenting to any rheumatology clinic with early morning stiffness. So I'm telling same thing again and again. You have to fit multiple things together. Don't try to harp on one single thing. Yes, if there is significant early morning stiffness, look more deeply, but always understand that even osteoarthritis patients can have significant early morning stiffness. If you have persistent fever, low grade, rule out your infections, but always think CTDs along with malignancies at appropriate age and appropriate examination. Hair loss in females is very common. It's very common. I don't take isolated hair loss as a new thing, but if it's profound, if you have patches of hair being lost like alopecia, you have other features, then definitely fit it into the puzzles. Dry eyes, dry mouth, almost every patient who comes to our clinic has a dry mouth, especially if they are on some antidepressants or some fibromyalgia medications. So I take dry mouth with a pinch of salt. But if the patient is saying that my tears are drying up, it's a very specific sign of possible Sjogren syndrome, because the differentials are very less. Mild dry eye is very common, and it's a very over diagnostic term in today's era, because many people are using screens, many people are continuously using screen, and dry eye is very common. So I will give importance to dry eye and dry mouth only, and if it is very debilitating, the tears are drying up, maybe you can do a Shermer's test, or the dry mouth is so severe that it is leading to dental caries in the front teeth. So if you have dental caries in the front teeth, always think that this patient could be a potential Sjogren's, because your canines and incisors are not very prone to caries, and usually this is a sign that the saliva is not being produced in a significant quantity, because saliva has an anti-infective property, and that is why they get caries very easily. I have seen patients who had a complete loss of denture at 30s, at 35s due to Sjogren's, and even the dentist could not diagnose it. But sometimes the dentist has referred to me saying that this patient has lost so many teeth at such a young age. Do you think it can be Sjogren's? And you can really help those patients. What kind of rashes? Any purpura, any diffuse maculopapular rashes is important, but any non-specific urticarias which are episodic, which are allergic, is not important. Erythema nodosum may be important, but butterfly type of rash is not seen extremely commonly. It is definitely seen in many patients, but not seen in almost 60% of patients. But you have to understand that facial rash or facial photosensitivity is very common in females, especially fair skinned females, and the close diagnosis can be melasma rosacea. So again, put things into context. Eyelid edema is very important. 1 or 2 days back, I got a call from Dr. Hina, who is a very good clinician in our area, and she actually picked up a patient of dermatomyositis with eyelid edema and some other classical features. And this was quite a brilliant pickup. And as I said, many clinicians are aware of these kind of things, and they can pick it up very classical patients. So chronic urticaria without pigmentation, occasional red spots are usually not useful. Always check for proximal weakness in patient with generalized pain and fatigue, because what I see sometimes these patients are not checked for proximal weakness, and sometimes myositis is grossly missed because you're concentrating only on fatigue, weight loss, fever, you're looking for infections. Nobody is actually asking the patient how bad they are in proximal. You have to look for proximal weakness, otherwise you will put it to generalized weakness, especially if the patient is complaining of new onset fatigue and weight loss or generalized pains. Always check their proximal muscles. If it is significantly weak, please think of myositis. The problem with CPKs in India is almost everybody gets so much steroid, and even a small amount of steroid can make CPK normal. So even in frank myositis, where I do an MRI and the muscle is totally white due to inflammation, sometimes I get normal CPKs because of even small amount of steroid reducing the CPKs. And getting a good EMG in our area is sometimes very, very difficult. So you have to rely on MRI and clinical picture, but you have to first do suspicions. Especially even in children, you can miss myositis if you don't ask for proximal weakness. Very young children sometimes drop their heads due to myositis, so you have to be very careful of that. When you have eye inflammation, always ask the eye person what you're thinking. If it is uveitis, it usually is seen in spondyloarthritis. Episcleritis and scleritis may be seen in RA or vasculitis, but usually in SLE patients, you can see optic neuritis or cotton wool spots. Anterior chamber doesn't get inflamed in SLE or other CTDs that much. Lung inflammation is very common in RA. It is not so common in SLE, but when you have sudden lung infiltrates, a lot of unexplained lung infiltrates, it can be Sjogren's also, especially if the lung infiltrates are with low hemoglobin and you have sudden breathlessness and the patient has recurrent such episodes with high CRP, with persistent fever. It can be a sign of diffuse alveolar hemorrhage. Remember that all these patients will give you some more clues. Do not think that all these clues occur in isolation. You have autoimmune lung diseases which can present in isolation with just lung symptoms, but even in those patients there will be some profile on antibodies which will be helpful. Not always, sometimes it is confusing and we just label it as undifferentiated, but always understand to see the whole picture. Recently, I saw a patient who is around 70 who is having persistent thrombocytosis. He has a persistently high ESR, persistently high CRP. Very good workup was done. Colonoscopy was done because he had anemia, which was negative. Upper GI scopy was negative. He had a PET scan, which was negative for malignancy. And ultimately, very high ESR and CRP, and his ANCA is strongly positive. So we think he has systemic vasculitis and just having systemic manifestations without any organ involvement. So you have to rule out your differentials, but always try to see the whole picture. And in sometimes intensivists, when they work in ICU, they should start think CTD very early, especially in multisystemic patients with no clear event. Maybe just pick up a phone call and call a RUMI, because they have to act very urgently to save lives, because these patients can become very severe and deteriorate by just thinking infection. Yes, in a right context, it may be too early to give steroids, but sometimes we have saved patients just because intensivists were good at calling us and we picking things at the right time. Things may evolve slowly or suddenly. So sometimes you might have only one symptom for 1 month and suddenly you will develop the second symptom. So don't think that CTD is present like classic textbook picture. 4 out of 11 SLE criteria are not seen at the same time. One criteria may be seen 6 months back. One criteria may come 6 months later. It is very unusual for all CTD patients to have everything at one go. It is always important to see what the ancillary tests are, like ESR and CRP. Lupus is low CRP without arthritis and pruritus. In CBC, thrombocytosis, if it's persistent, it can be sign of iron deficiency anemia, but you have to think of inflammation, especially vasculitis. Especially if you are suspecting vasculitis and you have thrombocytopenia, I usually start thinking of infection, because vasculitis should have thrombocytosis. But if you have leukopenia and thrombocytopenia, which is persistent with some fever, with some rash, young female, it is usually turns out to be lupus or some kind of CTD. Normal MCV anemia, which basically means that you have anemia of inflammation, not iron deficiency. You don't need ferritins and iron studies in every patient. Even these simple clues, if you give me a patient who has fatigue, who has pain, who has no other symptoms since ages, with normal CBC, normal LFT, normal RFT, no hypergammaglobulinemia, urine is normal, I will not investigate that patient further in most cases, because it's very unlikely to have a systemic disease without any clues on your CBCs, LFTs, RFTs. So please do your CBCs well. Please do it from good labs. Please try to see globulin levels, because we sometimes only do SGOT-PT. We don't do globulin levels, because if there is hyperglobulinemia, it means that there is persistent inflammation. And usually these patients will have high ESR. The problem with ESRs in India is many times they are not done correctly, because they are cheap tests and you get 50-60 ESR very commonly in many patients. So I usually trust hyperglobulinemia more. Always understand that if SGOT is more raised than PT, that what happens in myocardial infarction, it is a sign of muscle injury. So if you have massive transaminitis with normal liver ultrasound, normal hepatitis markers, always think if the patient has generalized weakness due to muscle weakness, because CPKs may be normal even with small amount of steroid. And I at least have 5 to 6 patients currently in last year where they had massive rise in SGOT PT, absolutely normal liver echo texture, which were treated as hepatitis, but they had pure myositis and their CPKs were normal, and that is why that confused the clinicians. Always see RFTs. How is the urine? Is there protein and pus cells? Do you have persistent proteinuria, persistent RBCs with negative cultures? Don't attribute it to mild diabetes. Don't attribute it to uh, the infections. Always think of other causes. Could it be glomerulonephritis? Could it be something systemic? And maybe involve somebody. Ferritins, especially if there are high ferritins, it can be seen in sepsis. Do not give undue importance to it. But if you have very high ferritins, very high inflammatory markers, persistently patient symptomatic, not getting any clues, you have to start thinking uh, CTDs. Chest X-ray infiltrates, it can be ILD, but obviously you also have to think of infections. In USG, you might get some diffuse small lymph nodes in many CTDs like Sjogren's, like SLE, like sarcoidosis. But obviously you have to make sure that you have ruled out infections. But again, in the right context, this can be a very, very important clues. So again, as I said, it's not only your ANAs. In fact, even before ANAs, if you give me your CBCs, ESRs, CRPs, LFTs, RFTs, urines, I can say with certain surety, with good clinical history, that the patient has CTD or not. And usually I tell clinicians and patients that I'm 90 to 95% right without reports or with basic reports on first visit of the patient. Yes, in 10 to 15% patients, we have to rely more on reports, but usually we are sure that this is going to be turn out some serious CTD or not if the patient is significantly ill, right, by looking at ancillary reports and the right clinical context. You don't have to do too many things in those patients, so you have to rule out the usual ones and then start suspecting CTD with the given clues. And that is how I approach multisystemic patients in my practice. Ultimately, we have to have the skin in the game or see patients on a routine basis. Most GPs in my area, I am very blessed. They are brilliant at picking up these patients. They are listening to the right webinars, I guess, and I am getting very mature diagnosis. And I think the GPs who get better with listening and learning, they actually send me patients with diagnosis. I have GPs who have sent me I will say many MD physicians in my area are brilliant. There are certain GPs who actually send me patients writing as CREST syndromes, writing as ankylosing spondylitis, and they do such brilliant workup at times that I don't have to do much. I just have to concentrate on the treatment. And even best roomies will get it wrong. I believe that sincerity and thoroughness is much important than the brilliance. Overdiagnosis is a problem with even roomies. I do not like to treat gray areas. If I'm not sure, I will call the GP. I'll tell the patient clearly, okay, I don't think you have the disease, or we will wait and watch. Sometimes the patients are not happy, and sometimes the patients are happy to listen that they were given a death sentence, okay, you have lupus, you have this, you have that. But I usually break it down for them and tell them ki it's better to use the terminology possible lupus or possible CTD rather than use the word lupus with arthritis, where you're going to subject the patient to immunosuppression and you have no clue that that is definite arthritis. You're just seeing some tenderness and you're labeling the patient as arthritis, because sometimes many people do that. They just squeeze the patient's hand squeeze is positive, this is early RA, give the patient methotrexate and steroids. 6 months down the line, patient is not even sure it is causing any relief, and they had fibromyalgia to begin with. Sometimes just observing very closely in very slowly progressive disease is way better, because at the first visit, if you don't feel that there is a rheumatic disease, it doesn't turn out to be that way, especially if the rheumatologist is very thorough with their examination and other things. And please do remember that 30% patients in rheumatology remain undifferentiated. You will use the word undifferentiated or seronegative arthritis, they remain untreatable and they remain GOK. That is, God only knows. They have persistent inflammation. We try DMARDs, but we are not sure what we are treating. And there is a very common joke between rheumatologists that it is some bloody autoimmune steroid responsive disease. So again, be very careful in giving steroids. The running joke among rheumatologists is no person coming to rheumatologist with persistent inflammation will go to grave without steroids. Though we use it jokingly, but we have become very, very careful in overusing steroids, and now we use it minimizingly, and we have understood that it is much common to see non-inflammatory generalized pain patients in OPDs rather than seeing frank lupus, because lupus and CTDs are not common diagnoses. You're talking of 1 in 1,000, 1 in 10,000 diseases, while fibromyalgia is so common today. But at the same time, just because a patient has generalized pain and there is nothing much on the primary clues, don't just label them psychotic or fibromyalgia. Be thorough, get the at least basic workup done, and then see, and don't attribute generalized pain to just vitamin D's and B12s. So I think we have taken enough theory. I will straight away come to examples. So basically, what is life without practice? And we will come to certain examples, and I'll give you learning points in each of them. As I've said, it's next to impossible for me to give you everything in one go. I'll try to conclude in next 15-20 minutes, and I can take a lot of questions after that. So very simple example I always give in all presentation. Lady referred with rheumatoid factor of 116 units, hand deformities. Her ANA was 3 plus speckled. And that ANA gave goosebumps to everyone in the family. They had read everything about lupus and everything. But when I saw her, she just have DIP deformities, no inflammation. Systemically, she was very well. They were categorical. We don't want steroids. I said, you don't need steroids because you don't have anything. You just have an ANA positive and a rheumatoid factor positive, but you are 60, you don't have any other symptoms, you have hand osteoarthritis, you can go home, no need to come to me. And that's why it's very important to have the right history and the right context. I got a doctor yesterday who had an young onset hypertension at 25. She's doing a surgery residency, and for some reason the cardiologist thought that in a young hypertension we should do an ANA. and the ANA came weak positive, and she was severely stressed out. She had no other features of lupus. Now, even if you have hypertension in lupus, you should have some nephritis to explain it. She had a normal kidney, she had a normal renal Doppler, she had a normal urine. Then how do you explain hypertension even if it's ANA weak positive and say it's lupus? So don't try to fit in everything into everything. Always see the right clinical context. I told her, do not investigate yourself. You are perfectly healthy. You have just got young onset hypertension. Maybe you need just a pheochromocytoma workup and maybe a renin angiotensin axis, but maybe it is stress, maybe that you have developed hypertension. You will not find the cause, but don't try to do autoantibody testing, because it becomes very cumbersome when you have a positive report to think of what to do, because you don't have any clinical feature. Your ANA is extremely weak positive, but her HOD is behind her to get multiple autoantibodies tested, and maybe she will get it tested, but I'm pretty sure that will turn out to be negative. So sorry for going on a tangent with another example, but I'm just trying to give you a different context here. So diagnosis here was hand away, go home, do a lot of exercises. You will have some DIP deformities. They will look bad, but you will not have functional problems, because in RA you have problems in PIP and MCP joints and there is lot of pain. In OA you have mild pain, but that is not very troublesome in your daily life. Even if it is troublesome, I'll give you some mild anti-inflammatories for a few weeks, do hand exercises and send you home. So I will not chase any ANA or other reports in her, especially for urine, LFT, RFTs. I'll just check the routine parameters. If they are normal, they will be sent home. Now, we saw a 55-year-old female on teleconsultation in April 2020. The history I got was she had episode of severe joint pains and joint freezes for 1 or 3 days, and it goes away in 3-4 days. So basically what she was complaining of palindromic rheumatism. If you have heard this kind of history, what happens in these patients, that it happens like a gout attack. You suddenly get one attack in any of the joint. Gout usually happens in the foot, but in palindromic rheumatism it can happen in hands, shoulders, anywhere. Suddenly that joint gets swollen, a bit warm, the patient cannot move that joint for 1 or 2 days, and it goes away in 1 or 2 days, either with an anti-inflammatory NSAID or just like that. This is a very classic history which is seen in almost 30% of rheumatoid arthritis patients, because they start with palindromism and they develop full-blown rheumatoid arthritis maybe 1 year, 2 years, 6 months, 3 weeks, or 6 weeks later. So I thought she had palindromic rheumatism, very classical on history. Sometimes I will ask them to do an ESR and CRP during the attack, because they go through sky roof, they become 60, hundreds, and they become normal in between the attacks. The patient is so normal in between the attacks, sometimes they are labeled as psychiatric. But now, at least the clinicians in Bombay have got very smart. They definitely do RA factor and NDCCP in these patients. So I started her on treatment. This was online. They had not shown any GP. I thought she will come NTCCP positive at least, but she was RF and NTCCP negative. Now this was going on for 2-3 weeks. I asked them to come in 2-3 weeks. By third week, she started developing these huge blackish lesions, and she had this profound hair loss. Her mane of hair was perfectly normal. She had this profound hair loss within weeks. This is just, we are talking of almost around 2 to 3 weeks. By around third week I was seeing her again, but she had started developing these massive lesions. In around 2 weeks she had almost 80 to 90% of her hair loss. And by that time, once the patient has definite arthritis and palindromic rheumatism, I will always do an ANA. So I had already ordered an ANA, and this was typical DLE like lesions. Now if you see her nose, I don't know if you can see that. If you see her nose, nose is completely covered by black lesions. It was like a malar pattern, but not a classical pattern. There were lesions everywhere on the face, very disfiguring. But she definitely had DLE like lesions. I was not 100% sure, but because she had a palindromic rheumatism, the lesion looked like discoid lupus, which are sometimes scarring and pigmentatory. Did not have a classic butterfly rash. The next suspicion was lupus, and she had a ANA which was strong positive. dsDNA came positive by ELISA. On blood, there were multiple antibodies. So it was a clear classical case of lupus, which developed very fast symptoms, and the family got very scared. But because I had counseled them ki it might turn out to be some other autoimmune disease. Given some articles, they ultimately got admitted because she was progressing very fast. I was worried about her developing. She also developed muscle weakness, so I was worried about her myositis. So we gave her a bit of IV steroids, and she was very concerned about the face rash. So we started her on mycophenolate, and I think she's at least now 6 months or 9 months into her illness. She's doing perfectly fine. Most of her rashes have disappeared, and she has gained almost 70 to 80% of her hair pre what she had lost. So lessons learned, sudden evolution despite you have started some treatment. So I gave her a bit of NSAIDs, and I already started on hydroxychloroquine. So in 2 weeks she suddenly developed this massive symptoms, so they can evolve. Though it was lupus like but not classical butterfly rash, and there was profound alopecia. We had not just talked about hair loss. Hair loss came very suddenly, very profound, which is very commonly seen in such patients. And then I thought of lupus. Multiple autoantibodies were positive, not single. Arthritis was present in the background. Everything pointed towards lupus. And there was no major organ involved. We thoroughly screened her urine. Obviously, for neurological symptoms, you need to have some symptoms. She did not have any major symptoms. We are regularly screening her urine for nephritis, but she's doing well currently on mycophenolate for almost 6 months with almost very good recovery. So again, this is very important. Now in lupus, if you have predominant arthritis, we use methotrexate. But if you have predominant systemic symptoms, we sometimes use mycophenolate. Mycophenolate doesn't work very well for arthritis. Sometimes you have to use both. So it may sound overkill of using mycophenolate and methotrexate at times together, but we have to do that in some patients if they have a nephritic or systemic component, because methotrexate doesn't work that well on the nephritic part of it. So we will see some rheumatologists using mycophenolate and methotrexate together. It's not very common, but we do use it in certain severe patients where we have to treat both the arthritis and non-arthritic component. Sometimes when we have to cover both, we use rituximabs because it works both on arthritis and the non-arthritic component. But obviously it is not extremely cheap, and it's very difficult to convince patients to take rituximab at the start. But we do use it sometimes. This is a 45-year-old dancer who had a burning pain in feet with possible ankle swelling on and off since 1 year. Now she had these new rashes. If you can see, there are very small, very fine purpura which were a bit palpable. She had a normal platelet count. She had a burning pain in feet over severe, which was last 2 3 months. She was not able to dance. Her RA factor was 353. So she was labeled as rheumatoid, but there was no arthritis as such. And her ANA was only 1 plus speckle pattern. Now it's very confusing picture. Even I was confused at the start, but it looked like she has a small fiber neuropathy. History. It was based on history. You can't prove a small fiber neuropathy by an NCV because NCV is meant for large fiber neuropathies. Either you need a skin biopsy, which is not usually technically done in India, or you go on history. Severe burning feet in a young female. If it was a diabetic, you will label it a diabetic neuropathy. But in this patient, no diabetes, no other comorbidities. We were looking at a small fiber neuropathy on a background of a very high RA factor with some palpable purpura. So my initial thought was this is Sjogren syndrome. We did her LFT. She had a very high globulin level. Her anti-Ro antibodies were strongly positive and had a low C4. So again, not isolated Ro positivity. You have a patient who has a very strong RA factor. She has a burning feet. She has a palpable purpura. She has Ro antibodies. She has low C4. She has globulins. She did not have Sicca symptoms. She did not have much dry eye, dry mouth. But this is classical non-Sicca presentation of Ro antibodies or Sjogren syndrome. So this is Sjogren syndrome because small fiber neuropathy is very classical in Sjogren's. It's not very common, but it's very classical. Anti-Ro, low C4. Again, low C4 is commonly seen in Sjogren's. In SLE, you see both low C3 and C4, but in Sjogren's, you usually see only low C4. And she had a high hypergammaglobulinemia, and hypergammaglobulinemia is again seen very commonly in very severe Sjogren's patients because their IgG levels go very high, above 18-20, normally is above 16. And she had a primary Sjogren syndrome with small fiber neuropathy. Now understand that this patient does not have classic dry eye, dry mouth. And sometimes most systemic patients don't have this disease. Now this patient is a big defaulter. Around 6 months back, she almost developed a quadriparesis because she also started getting mononeuritis multiplex in all her four limbs. So initially we kept her on methotrexate only because small fiber neuropathy was not very aggressive and she responded very well. But because she defaulted on treatment, she went to develop a large fiber neuropathy to an almost bedridden status, and now she has received 4 doses of cyclophosphamide. She has again disappeared from the scene, so I don't know what next she will present. But she was a patient who had some clues even 1 year back. So what were the clues? RA factor positive is not always RA, doesn't always need to have arthritis. You need to have multiple clues, which this patient had, which she already had a burning feet with a positive RA factor. Later, she also got a purpura. Maybe if you had done an LFT, we would have gotten hyperglobulinemia. Yes, if you get a severe hyperglobulinemia, you should always rule out myeloma. But if you do a protein electrophoresis in these kind of patients, what you will get is M band negative but generalized hyperglobulinemia. So if you have globulins which is increased on LFT, it is a very simple clue to start suspecting persistent inflammation. Obviously, that is not the lone sign. You can see that in infections also. But if you have a chronic patient and hyperglobulinemia, you have to start thinking of persistent inflammation. A strong positive RA factor in young female is usually harbinger of hidden Sjogren's. I've seen patients where I've sent them home saying that your RA factor is non-specific. You go home and they have suddenly presented with renal tubular acidosis and hypokalemic paralysis. So I remember a patient who had a RA factor of 100. I told her you don't have anything because she was clinically absolutely normal. I should have checked her potassium and bicarbonate, but I did not. 2 months later, she presented in Pune to one of my friends with hypokalemic paralysis. So we have learned it the hard way that if you have a strong positive RA factor in young female, I usually look for renal tubular acidosis or hidden Sjogren's. But even again, if they don't have symptoms, I will not treat them. I'll just keep it in mind and tell them if you have a low potassium, correct it. But we'll not usually ignore a strong positive RA factor in a young female. Yes, in old people, if they don't have clinical features, even a strong positive RA factor, like we did it in the first patient, I will ignore it if there is no clinical history. But in young female, even if they don't have symptoms and somehow somebody did their RA factor for some reason and it is come strongly positive, they don't even have arthritis, I will at least check their ANA blot for ROLA antibodies and just keep a close watch on those patients. And always check their potassium and bicarbonate levels because sometimes bicarbonate levels are low with low potassium levels, which may detect hidden renal tubular acidosis, and sometimes they may go into severe paralysis. So this patient is a 60-year-old male presented with chest pain, referred for angiography. He had mild fever and sweating. His angiography was normal. He had some rashes on lower limbs, and dermatology thought there is skin vasculitis. I was called, and I said ki I think it's not specific. We'll wait and watch because we had already ordered the workup. He was stable, but his in fact his CRPs and ESRs were also normal, so I did not think much of it. But he was discharged and readmitted after 2 days with fever and breathlessness. uh, so his ANA was 1 plus. I was again called. Patient was on CPAP ventilation. There was some infiltrates on X-rays being treated as infection and low C3 and C4 normal. And I was told that this is vasculitis, you give steroids to the patient. I said ki no, the patient has infiltrates on X-ray. We don't know what those infiltrates are. He does not have persistent thrombocytosis. He has high CRP now, but he had a CRP which was normal. The lashes look like vasculitic, but it can be precipitated by infection. Again, if you have low C3 in a vasculitis setup and you're not suspecting lupus, it usually can be a sign of infection. So what I told them ki you first bronch the patient, get some cultures, show me that those cultures are negative, or get some transbronchial biopsy and show me some evidence of vasculitis on those things. Because if you had biopsy that skin, you will have shown vasculitis. Now do understand that vasculitis in skin can be a reaction of many things. It can be a reaction of infection also. So you don't have to harbor on that. You have to be very sure, and ultimately patient had low platelets, so you need to have very high platelets in vasculitis, but the patient had low, so I thought of infection. But sepsis looked very lightly, culture day to no growth, so we bronch the patient. And we also look for infective endocarditis. Bronchoscopy lavage actually grow both pseudomonas and candida. God only knows where it came from, but patient was much better with antifungal treatment. The patient was already already getting pseudomonas. We think that the initial chest pain was just start of an infection. He ultimately went home after 25 days But thankfully, we did not give him steroids based only on those clinical picture. We thoroughly stick to our history and made sure that we ruled out infection. So this is a learning point for all intensivist and even MD or GP physicians. So not every purpura is due to autoimmune vasculitis or disease. Always think infection and rule it out before subjecting to even steroids, and fit everything together. If you are not sure, do more investigations, but do not try to give steroids at a very early stage, especially in a patient who has some infiltrates. Try to get a clear-cut histopathological diagnosis. Now, this is a 50-year-old male who had severe fatigue, unable to do normal activities, lot of pain everywhere, new onset. ANA was weak positive, but cytoplasmic pattern. CPK normal. I think this patient was referred to me by, if I may name the GP, Dr. Gidan Gada, who picks up brilliantly some patients. And somehow this patient was having massive transaminitis around a month back. He was admitted for almost a month and a half, and no cause was found, but he gradually recovered. I don't know whether he received steroids or not. And he had massive weight loss and a lot of almost 10-15 kgs. He was not able to get up. He had one limb hip disfigured since childhood, so some people thought he is having problems due to that. But somehow Gedan sir picked it up. He sent it to me. If you see, his face was quite unusual. The skin was hard, and he had, I don't think you can see it, but this part of the neck was quite red. It is not very clear, but anything above his gold neck chain was red, which is classic V rash of myositis. He did not have any eyelid edema or heliotrope rash, as we call it. But this history of SGOTBT greater than 1,000 with absolutely normal liver on ultrasound also made me think that this is myositis. His CPK was normal, but again, as I said, it's very difficult to in India, it's very difficult to rely on CPKs. He was very, very weak proximally and very much in pain. He did not have much arthritis. It was pure myositis, which was giving him such amount of intense pain, which made sir to send to me. And this was classic dermatomyositis with some scleroderma-like overlap. His ANA blood had Jo1 positive. That's why the ANA was showing cytoplasmic pattern. So ANA was weak positive, but this patient still had a severe disease. He had a lot of MRI muscle edema, which proved that he has myositis. I did not need an EMG. There was no eye rash, but he had a V rash, which is classical. Always look for V rash in old patients. If you're having generalized pain, just ask them to remove shirts, because it's for some reason quite common in males with dermatomyositis. Dermatomyositis is not a very common diagnosis. So again, but if you have a patient with sudden pain, sudden problems, you have to rule out infections, rule out malignancies at this age. But this had patients had severe feature. Now, if you have dermatomyositis, you do rule out malignancies any which ways, but he had myositis, which was causing the problem. So learning point here was negative or near negative ANA, very important in CTD. Uh, does not mean that they have ruled out CTD, because some CTDs can have negative ANA. And this patient should have been probably picked up with transaminitis stage if that clearly looked at his generalized weakness and looked at muscles specifically, because he had severe myositis by the time he came to me, almost to the point that he came on wheelchair, but CPK was okay. And again, there were a lot of other clues to say that this is the patient. And again, we did not just harp on ANA. Now, a 40-year-old female with fever and severe joint pains. This patient presented to me yesterday. I just wanted to give you a clue. She presented with fever and severe joint pains. The husband had the similar episode. Both husband and wife, they were living here. They wanted to go to Dubai, but they were waiting for some clearance. So they got fever same time. Both got rashes. In female, it was attributed to probably etoricoxib. She already had got COVID in May, but was negative this time. After 4-5 days of whatever treatment they got, they were admitted in the hospital. Dengue, malaria, everything was negative. There was no leukopenia, no thrombocytopenia. Patient had extreme joint pain. Chikungunya was not done. The ANA was weak positive. The Rho was strongly positive. The RF was negative. The CCP was negative. There was no Zika symptoms, and everything started with fever. So now she was referred to another rheumatologist with a strong positive Rho. But if you see this history, this is classical post-viral arthritis. Now, this Rho positive, I did not see any symptoms in the patient. So I think it was just a bystander antibody. And she was actually advised rituximab. And that's why my WOA, because it's quite an overkill actually, because if you see her reports, her CRP had gone down from 55 to 2.8 without steroids. She had extreme pain but no swelling. This is very classical post-viral arthritis. You won't see any inflammation in the hands, but if you touch the patient, they will be extremely painful. So this was looking like classic post-viral arthritis. I told her that she's extremely unlikely to be CDD. I might give her a short course of steroid plus HCQ, which I did, and reassured her that this is most likely to self-heal on its own, as most post-viral or chikungunya people do. I've ordered a chikungunya test in her, but it's almost 6 weeks. I don't know whether the IgM will be positive, or it can be some other post-viral arthritis. You cannot check for every arthritis, but you have to go with the clues. This patient does not have Sjogren's. Everything started with fever. Sjogren's does not start with fever and 1 day of arthritis. This is typical viral. Most likely she had rash along with it. And even if I think she's going to develop Sjogren's, we will keep a close watch. I will not chase reports for now. I'll fit the clues and I will ask her to follow up and see whether there's anything new developing. But at this point, doing overkill will be harmful for her. Similarly, another patient, 18-year-old female, not similarly, another patient, 18-year-old female, muscle pains, 3 admission over 6 months. CPK always is 2000 to 3000. In fact, when I saw her, there are no other clues. There is nothing else on the features. I told her physician GP, her GP called me in the clinic, she is having a lot of trouble. Can you sort it out? I went to the clinic, saw that patient there and there. And I said, sir, I think it can turn out to be something genetic, but it is new onset. So I think we should investigate. She had a full-blown SLE picture. She had a ANA strong positive homogeneous. She has a dsDNA strong positive by ELISA. Her blood had at least 4 to 5 antibodies. Her MRI showed active myositis. But she also had mild tachycardia and eco normal, and I gave her beta blockers and we started her on 1 milligram per kg of steroids. But because she had tachycardia, and I know that sometimes they have severe myocarditis which can deteriorate very fast, I told father that if she doesn't improve in 2-3 days, please call me. I got a call on Saturday morning out of station because she's breathless. I told her to go to any hospital nearby. I asked them to come to Wokhad Mira Road, but they went. I told them, even if you want to go to some hospital in Virar, you go, but please admit her and ask them to call me. Next day at night, I got a call from hospital. She's brought dead. And when they tubed her, there was massive frothing and she possibly died of a myocarditis with tachycardia. If you have a persistent tachycardia, it starts failing your heart. So you have a sudden dilation of heart and it leads to pulmonary edema. And we lost that 18-year-old female. I still have regrets that maybe I should have asked them to admit when I found mild tachycardia and give her cyclophosphamide. But in a young female, to give cyclophosphamide, it becomes very difficult to subject them to cyclophosphamide straight away. Not that it is not, it causes sterility or something, because it's very safe below 25 or 30 years of age. But I just thought we can wait for 1 or 2 days. And somehow the father was frustrated with the system. We should have investigated her earlier. Myositis was picked up. Why a proper workup was not done, I am not sure. With non-classical clinical features, but a young female with new onset muscle weakness have to work up for CTD. Myocarditis can be deadly, and probably that failure of our system to not convince the father in the first 3 visits when we actually admitted the patient. He was frustrated with multiple admission. There was no dearth of money. He had just had unclear answers and they were fearing the next admission. And that is why they delayed it for 48 hours and we ultimately lost the patient. So somehow, sometimes I feel that it's our system which possibly lets down the patient than the patient's disease itself. This is a patient who presented with severe ILD. But if you see, she has classical hands. You might think that she's working in kitchen, but this is known as mechanics hands. So I always look at hands. Just looking at hand and face can give you a lot of clues, because in face you can have eyelid edema, which can be a sign of myositis. Looking at some body rashes like a classic V rash at the neck, you can get a clue. Looking at hands, if you have rash on knuckles, it can be a sign of myositis known as Gottron papules, especially in children. If you have this extremely rough hands, especially on the radial side of fingers, it can be mechanic hands, especially if the patient, don't start thinking mechanic hands in every patient. But this patient had a lot of features. She had a lot of dyspnea on exertion. She had myocarditis. She had a lot of ILD. her myositis antibodies were positive. So but it all started with seeing her hands and seeing her history, because there were so many clues. We did a lot of investigations and we ultimately could diagnose her. This is known as anti-synthetase syndrome. It's a type of a myositis syndrome where you have certain antibodies positive and you have a very high likelihood of autoimmune ILD. So again, hand and feet and face can give a lot of clues. This patient is a classic scleroderma patient. What I wanted to show, that you see this salt and pepper appearance. It's like salt with pepper sprinkled on it. This is very classically seen in many MCTD, mixed connective tissue diseases, and scleroderma patients. So if you have any patients with Raynaud's, if their fingers get unusually cold, or they become white, or they become bluish due to cold, or they have persistent bluish discoloration without any blockages, with their pulses being normal, with this kind of picture, it usually will turn out to be some limited scleroderma or mixed connective tissue diseases. It's very, very uncommon to have mixed connective tissue diseases or scleroderma with no Raynaud's. So if you have a patient who has some tight skin at one place but no Raynaud's, it's very unlikely to be having systemic scleroderma. Again, explaining that why clues are important. This is a very funny patient. 3 years back, she was possibly my first patient in Wokhart who presented with to hematologist for anemia. That time she had arthritis. That time my first paper mentioned that she most likely has lupus. Her ANA was 3 plus, her dsDNA was positive. We gave her a spot amount of steroids and methotrexate. She took it for 1 month and she was lost to follow. Now she did not have Raynaud's then. Now 3 years later, she was completely fine for 3 years. 3 years later, now she is presenting with this finger. You see this blue finger, the blue finger in the left little hand. She classically, usually Raynaud's, we say you go into that stage of pallor where the blood vessels become constricted. You get a stage of pallor, then you get deoxygenated hemoglobin and you get this bluish discoloration. But she presented with severe pain in this finger. So much so that I thought that this will become gangrenous. So we immediately started her on vasodilators and she got much better with those vasodilators. Coming to the end, this is a patient. So this is a patient with lupus, but currently she does not have any arthritis. She just have this problem. So I will just treat her this problem of hers. I will not give her anything else. I will not give her steroids because she is having one symptom. So again, when you are treating a multisystemic disease, you have to treat only the part which is causing problem. You don't have to give steroids in everybody. You don't have to give steroids in every scleroderma patient because they can be risky and they can cause scleroderma renal crisis. So always remember the context. This is a very funny patient, recently was admitted with us, and if you see, he had got first very light rashes and very severe fever for 15 days. So a very good physician, Dr. Shankar Narayan, I'm not sure if he's listening here. He referred to us from Dhavle Hospital in Palghar, I think, where he had worked up the initial workup. All workup was negative. When we are admitted, the rash was very faint. I was totally unsure what we are dealing with. His ferritin was high. So I thought he has adult onset still disease. But slowly this rash got darker and darker. Now, if you have remember your medicine, this is a typical purpuric rash, but you see this this is a net-like pattern. It's like forming nets. This is classical livedo reticularis. Now, if you have livedo reticularis, it can be non-specific, but you have to start thinking of antiphospholipid antibodies because it's almost like cutaneous infarcts here. You have to start thinking of other systemic diseases. And sometimes it can be part of some non-specific autoimmune diseases also. So we did a lot of things. His antiphospholipid antibodies came very strongly positive. Somehow diffuse antiphospholipid syndrome does not present with fever, but he possibly had a lot of cutaneous reaction with lot of inflammation, which led to hyperperitonemia and presentation like Still's disease. So a lot of things combining together. His ANA was negative, but he has an SCL 70, scleroderma 70 antibody positive. Now this patient does not have scleroderma. So again, a classic example where you can't judge one antibody. You have to see the whole picture. His picture is like a diffuse antiphospholipid antibody syndrome like picture with possibility of infection. Always remember that this kind of purpura can also be seen in severe pseudomonas sepsis, what we call as purpura fulminans, or even meningococcemia. So we made sure that he did not have any neck stiffness, neck rigidity, no signs of meningitis. We did his blood cultures. We were absolutely sure. Then by fourth or fifth day, we got his antibodies. We started his steroids around fourth, fifth day because he was having persistent fever. We have discharged him of a tapering course of steroids. He's doing perfectly well. All these lesions have really dried up, and we have started him on anticoagulation. So even in best of the cases, we might take at least 7 to 10 days, but we were very clinical, very sequential, and slowly we got to a diagnosis. This is a patient who has just presented with eyelid edema. This is a patient who has got myositis antibody. She does not have myositis right now, but she might develop it in the future. At this moment, we have given her treatment just to make this better because it's looking so dramatic. And sometimes you can get this dramatic heliotrope rash in such patients. This patient is very funny history. She had inflammatory seronegative arthritis, definite inflammation like rheumatoid 4 years back. She took methotrexate steroid, got better. Now, if you see her eyelids, you see this part is totally erythematous, the upper eyelid and the lower eyelid. This is classic heliotrope rash. And she has anti-Jovan, that is the myositis antibody positive. Even she does not have the myositis, but this part causes her severe pain, and she just has arthritis and a heliotrope rash. She does not have myositis, but because this is so classical, we could actually do her antibodies. Previously, they had just done an RF anti-CCP because she just had arthritis and she was seronegative. And ANA was not done. I think ANA was weak positive or cytoplasmic because Jovan can be negative. The ANA can be negative in these patients. So again, after 4 years, she has developed something new. So in CTD, you have to always keep a lookout, and always when the patient diagnoses seronegative arthritis, I always tell clinicians that they might turn out to be something else 3-4 years down the line, which was the case with this patient. Ultimately, we will still treat with methotrexate, but it helps to know, because suppose if she develops muscle weakness, we know that she has a disease which can develop it, and we can be a bit more aggressive. But in her case, right now, she just has arthritis and eyelid edema. So we have just given her hydroxychloroquine, which works well for facial rashes, and some methotrexate. Sorry, but I cannot harp on treatment part too much. But ultimately, what I will tell is we treat with the severity. If there is no major organ, no kidney, no CNS involvement, no severe neuropathy, no severe blood vessel involvement or autoimmune hemolytic anemia, I'll usually use methotrexate and hydroxychloroquine or small amount of steroids, and sometimes symptomatic. For example, if you have Sjogren's with just dry eye, dry mouth, I will just use symptomatic treatment. I will not use immunosuppression. But suppose if you have a patient with major organ like kidneys, like blood, autoimmune hemolytic anemia, severe myositis, we may use high dose steroids with methotrexate, we may use mycophenolate, we may use cyclophosphamide, and we may use rituximab. This is the usual gist of treatment in rheumatology. And azathioprine and cyclosporin come somewhere in between. These are the most common drugs we use. Very rarely we use leflunomide and SARS and sulfasalazine in these kind of patients, but these are the only oral or IV drugs we use. And with judicious steroids, we have come down with use of steroids very much less. We sometimes use 0.5 milligram per kg only, not 1 milligram per kg. We taper it very fast. We try to be more intensified with mycophenolate and rituximab earlier, so that we have to taper steroids very fast. If there is a young female, I will not use too high dose steroids because the risk of AVN is very high between 20 and 40 years of age. Usually avascular necrosis does not happen above 50 and below 20 for some reason of mechanistic reasons. I will not go into details. So if the patient is between 20 and 50, I'm very wary because I've seen very bad AVNs requiring hip replacement, especially lupus patients. So we sometimes now, even in severe patients, give cyclophosphamide 1 or 2 doses early, and only give a 0.5 or 0.35 milligram kg of steroids, even in the severest of the disease. Yes, some patients will require a higher dose, but at least in 70-80% of the patients, we can get away with a lower dose. So lastly, GP's most important role will be trust, education. Please motivate your patients. I am very blessed with very good GPs around me who counsel patients well. And that is what we need, because these are diseases like 1 in 10,000, 1 in 20,000. Most people don't understand them. I do try a lot to educate patients, but sometimes when a GP reinforces the trust, it's very useful. We need to maintain these patients with targets. We just don't want to make them symptomatically better. We need to completely control the disease. For example, if you don't control myositis well, they will be left with lifelong proximal muscle weakness. And I see patients after 8 years of myositis who can't get up from bed, who need support, who cannot go on trains, who cannot walk, just because they were not aggressively treated. Because you have to achieve complete remission. Partial remission is not a target in most patients. You will always try to achieve complete remission. Yes, if there are complications, then you will go with a lower target, but always achieve targets. And that's why a rheumatologist is very helpful, because they will not stop at partial treatment. They will try to achieve complete target. First line of referral for any side effects should be the norm. We have to use steroids sparingly. Lower is better, but sometimes we have to continue using what we have been using in the past, but we have become better with research. In these patients, you should use cultures very thoroughly, especially if they have a urine infection, because they are on such immunosuppression that without culture, it becomes very difficult. But sometimes you should also start antibiotics very fast. For example, maybe you won't start antibiotic in a patient with diarrhea otherwise routinely. But if a patient is on rituximab, high dose steroids, then you should be very careful. Do not stop steroids suddenly. If they are on, suppose, say 20 milligrams steroid and they have got a severe infection, make it 10, but don't go below 10, because you need 10 milligram for your stress in the body. So if they are taking outside steroid, they cannot produce their own steroid. So don't go below 10 milligram if they are taking steroid for very long. Sometimes if you are taking 2.5 milligram also for very long, during an infection, we might have to increase to 7.5 milligram. If you have a bad feeling, you don't feel the patient is good, I call it clinician's intuition. If it is not looking good, refer immediately or maybe admit the patient. So the take-home points will be easy to diagnose CTD in many, but easy to miss also. May become very serious and life-threatening if diagnosed late. I've already given you examples. Often delay in diagnosis is due to medics. We as Bethan missing clues. Fitting many things to make CTD diagnosis is the norm. One single event or one single report is very unlikely to be a CTD, and report and diagnosis may not match even for the most specific tests. So I'll end it here. I'm sorry for going a bit overboard, but I hope this was enticing.
Saira, many questions
So
posted.
there are
There was
no.
a question in the chat, I guess.
Yes, sir.
So there is a question in the chat box.
Hmm.
When drug to avoid during lupus and CTD.
People have asked about what is drug-induced lupus, and is can we avoid some drugs during lupus? What I usually tell people ki there are you can use almost everything. Drug-induced lupus is an entity which is usually seen with methyl dopa or hydralazine or penicillamine, but it's not very common. I have seen omeprazole induced lupus also, but there is no drug which you can technically say you have to completely avoid during lupus as such. You have to again see the right clinical context and then take it from there. I think that
Okay.
answers Subhash sir's answer. Maybe you can unmute Subhash sir, and maybe he may want to ask something more. I don't know
So
what.
can I ask that
Yes,
question? Can
yes,
you
sir.
give NSAIDs easily in lupus
Yes, sir.
and
Yes, sir. We do give it very easily, except if the patient has lupus nephritis. In fact, I have to use a lot of NSAIDs because they have a lot of pleuritic chest pain, sir.
Hmm.
Definitely, I use occasional NSAIDs in many patients. I tell them ki you can take naproxen in 250. I try to see what is the lowest possible thing we can achieve. Some lupus patients have, sir, constant fatigue and pain. So you have to sometimes allow them to give a bit of paracetamol daily with proper LFT monitoring. But if you see the guidelines, sir, even in foreign countries where lupus does not, lupus and kidney involvement is a very Asian thing. So Asians are more likely to develop lupus nephritis. But if you go to UK, US, Caucasians, especially non-African Americans or Caucasians, pure Caucasians, don't develop nephritis that easily. In those patients, they use NSAIDs very commonly. In our patients, we are a bit careful, but occasional NSAID use definitely yes, pleurisy definitely yes, but we keep a close watch on any lupus patient should have a urine monitoring at least once 3 monthly. So we keep a close watch any which ways.
Okay, sir. Thank you, sir. Thank you.
Yes, sir. Bye. Okay. So how should we treat chikungunya is one of the question. Is I'm right? Yeah.
Yes, sir.
Yeah, so I think chikungunya, the whole point is if the fever has gone, I will see what is the amount of pain. Monitoring at least once 3 monthly. So if the pain is very intense, inflammation is very intense, I will use steroids. We don't use steroids in the feverish phase, that is usually known as the viremia phase, because we don't know how it will respond. I'll use steroids. There are some randomized trials to say that you can treat chikungunya like a rheumatoid. You can use methotrexate and hydroxychloroquine. I'll definitely give hydroxychloroquine if there is pain at least 4 to 6 weeks after the fever has gone. So some NSAIDs, some steroids, maybe methotrexate if the CRPs are high and inflammation is seen. But if the inflammation is not seen, I will give hydroxychloroquine. I'll give some prolonged NSAIDs and some low dose steroid till patient becomes symptomatic and concentrate a lot on exercises. I got a call from gynec recently who is taking 1 milligram betnamethasone 3 months also after chikungunya. She says ki if I don't take it, I cannot work as a gynecologist. I can't do my surgeries. And she's right, because the pain can be so bad. And I thought ki 1 milligram betnamethasone is almost equivalent to 3 or 4 milligram visolone. So what I've told her ki ma'am, you try to decrease it alternate day, try to add hydroxychloroquine, and let's see what happens. Maybe when hydroxychloroquine starts working, it usually takes 4 to 6 weeks. Or we may add methotrexate in her. So I will treat like rheumatoid arthritis depending on the prolonged pain. But do understand that most chikungunya arthritis patients self-resolve in 4 to 6 weeks. You just have to give them NSAID support. I think Raza sir has asked what is cause of post-viral arthralgia. Sir, there is multiple theories. Basically, everything autoimmune, you have some event which triggers immune reaction. Your immunity gets hyperactive and it starts attacking the joints. I will just put it that way. Joints are for some reason favorites of autoimmune disease, and that's why rheumatologists, despite being autoimmune disease specialists, will always be known as arthritis specialists because they see so much joint pains. Meena ma'am has asked how long you give naproxen safely. Ma'am, there is no answer to that. They have found that even in elderly, naproxen has less cardiovascular risk. So I use naproxen, but no NSAID is safe. I always tell patients ki if you are using naproxen, try to monitor your creatinine. Some people see a creatinine going from zero point 0.8 to 1.1 and they see the range as less than 1.5 and they consider it normal. I always say ki if you have a 20-30% rise in creatinine, even if it's within normal range after an NSAID, be very cautious. I will take off NSAID and probably give a smaller amount of steroid in that patient because at least steroid does not affect the kidneys. So in every patient, we will see a different scenario. I use more NSAIDs in young post-viral arthritis, less NSAIDs in old. I use less steroids in young because they develop a lot of cosmetic side effects and slightly more steroids in old. But this is a very general statement. Again, it will depend from each and every patient to patient. Please do not generalize it. Okay, ma'am, Vinny ma'am has asked me whether there is an acute onset bilateral sacroiliitis since 8 days with acute injury, creat, high D dimer, PCR COVID negative, acute onset progressive breathlessness in a 42-year-old female case of diabetes and hypothyroidism. Ma'am, my first suspicion will be whether this is infection because staph infection can lead to sacroiliitis. Now, bilateral sacroiliitis is very uncommon. I will treat like infection, give her hydration, but I will try to find cultures, see whether the sacroiliac region is developing abscess or not. I'll get a full autoimmune profile because this is very unusual presentation. It could also be the fact that the patient already has bilateral sacroiliitis since quite long and the patient was taking NSAIDs and that has led to kidney injury. So multisystemic disease, sometimes I use the word ki itna khichdi ho gaya hota hai. You have to separate the rice and dal and spices and then start from the basics. So what I do in these kind of patients where no head and tail is there, I just give them symptomatic management. I usually avoid steroids or I give a very low dose steroids. we start treating the symptoms like kidney injury with adequate fluid management, and we start doing workup. More often than not, there is something which they are taking in the past, either an Ayurvedic or herbal therapy, which has led to these issues, or they have been misusing NSAIDs. And if you can't get that history, treat symptomatically, treat like an acute event. I will give a empirical antibiotic and just keep a close watch on how things are happening. We do this in almost 30% of patients in ICU where I am clueless, where I'm getting some clue of autoimmunity, but I'm getting no other things. So maybe in this patient, you will have to do an HLB27, an ANA, how to see her urine report and see how things go. Funnily enough, we have seen some SLE patients developing sacroiliitis, and we don't know whether it is related or not. I have seen at least one recent patient who had got a severe purpura, diffuse purpura, Henoch-Schönlein purpura with GI vasculitis. He had a GI bleeding. He had bilateral sacroiliitis also with that. And everybody is clueless whether they are related or not related. Now his Henoch-Schönlein purpura has completely improved with steroids and MMF. He is just now left with sacroiliac pain, and his MRI of sacroiliac joint is still showing sacroiliitis, which is much lesser than compared to earlier. But he's HLA-B27 negative, he's all antibodies negative, and God only knows, but he's much better than what he was earlier, and we have just continued him on methotrexate. So it's a very difficult world out there, and I think this is a very difficult patient. Okay, so I got patients on AKT gets myositis, proximal muscle and joint pains. So first of all, if patients get AKT, when you use the word myositis, I don't know if it's a sir or ma'am. Sorry, I'm coming back to Vinny ma'am's patient. Ma'am, can it be CTD? Yes, it can be CTD. I've already told you, I'll do everything, but don't expect great answers. I think you'll have to go by symptoms. Sorry, coming back to the AKT gets myositis question. What you happen is pyrazinamide is very arthralgia inducing. INH is also known to cause something known as shoulder hand syndrome, where you can get a frozen shoulder or you can get severe myalgias. Now, when you use the word myositis, I believe that you should use the word myositis only when they have muscle inflammation severe enough to require steroids. So if they are severely proximally weak with MRI showing muscle edema or EMG showing some evidence of myositis, they may need steroids. But this is not common with AKT. What happens with AKT? They get severe joint pains and muscle pains, especially after 4 to 5 months. Usually it is pyrazinamide or INH induced. In most patients, you cannot stop pyrazinamide or you cannot stop rifampicin or isoniazid. So I give them low dose NSAIDs and they do very, very well. If I always do a marker of lupus and other things, because understand that pyrazinamide can induce lupus. So the theory is that these patients who are taking pyrazinamide or rifampicin may get a mild drug-induced lupus, where the ANA may become weak positive and they get a mild joint inflammation due to that. The theory that the hyperuricemia causes arthralgia is not very strong. So I understand that many people give hypouricemic therapy and it helps the patient, but I think it's just a placebo effect. More often than not, the explanation is that these patients getting severe arthralgia have got a bit of drug-induced lupus, but because it's not very serious and the drug is very important for the patient, I just give them NSAIDs and maybe I'll give them hydroxychloroquine. If there is very severe arthritis, it's very uncommon. If there is a lot of inflammation, then I will treat like any inflammatory arthritis. But usually what you are talking about is patients having a lot of myalgias and arthralgias. They don't have frank inflammation. And even the uric acid can be normal. Even if it's abnormal, I will treat them with NSAIDs. I usually don't give hypouricemic therapy because usually the pyrazinamide stops in 2-3 months and the uric acid comes normal after that. Okay. How to differentiate between hypothyroidism induced muscle weakness? Very good question, Shagufta ma'am. Hypothyroidism can lead to muscle weakness. Vitamin D deficiency can to lead to muscle weakness. But in those patients, your CPK will not rise, your SGOTs will not rise usually. If you do an MRI of their proximal thigh, they will not have clinical muscle wasting or muscle edema, sorry. And more often than not, the amount of muscle weakness with hypothyroidism and myositis will not be profound. Hypothyroidism and vitamin D deficiency is not as profound. Now let's take it the other way. Suppose I find a person with proximal muscle weakness. The patient is not ready to do MRI. There is significant weakness. I feel the weakness is quite significant. I'll always check their thyroid levels. If the TSH is very high, I will first treat the thyroid and see. I will always give vitamin D to any patient with muscle pain, even if it is low or not low. Wait for 20-25 days. If this is due to hypothyroidism and patient is not deteriorating, vitamin D gets normal, patient is better, there is no problem. But if the patient has lot of muscle weakness, I'll push for an MRI and a CPK and SGOT-BT, and then take collectively. Again, the answer is take everything in clue. If you're not sure, give treatment for what you think is the problem. Tell patients that we may need to investigate again. And most times patients are okay with investigations if you have told them before कि हम ये करके देखते हैं, नहीं होगा तो हम next step पे जाएंगे. I always tell them in rheumatology, you always tell them you give one drug for RA, no relief, you give second drug for RA. You give some steroids, no relief, you move on to the higher drugs. So always do that in rheumatology. If you're not sure, do not subject to steroids. Treat what you find is abnormal, and if it can explain the abnormality, treat the hypothyroidism. But suppose if you have mild hypothyroidism, your TSH is just 7, 8, your free T4 is just borderline or normal, I don't think that can lead to severe muscle weakness. So if the muscle weakness is mild, treat it. Maybe don't investigate it. If the muscle weakness is severe, investigate whether the CPKs, SGOT-PTs, ESRs, CRPs, LFTs, there is no hypergammaglobulinemia. So as I said, if there is severe inflammation, you will have some other clues. You will never get isolated muscle weakness in a pure myositis patient. That used to be called as polymyositis, but more often than not, if you ask a rheumatologist, we don't use the word polymyositis. Most myositis patients have an underlying lupus-like disease or a clinical skin involvement, what we call as dermatomyositis. Isolated pure myositis without having lupus or without having dermatological features is very uncommon. So again, you will get lot of clues in the history. Ma'am, Vinny ma'am has said no fever and counts normal, ma'am, God knows. So if the CRPs are normal, I'll start investigating for lupus and other things. I'll start with HLA-B27, maybe get a kidney biopsy, and sometimes you can get lupus nephritis without having anything else also. So I will talk to the nephrologist, I will see the patient's background, I'll ask for a thorough history, grill them that whether they are taking anything in the past or not, and then take it from there. Maybe we can discuss this personally, ma'am. Okay, so Rheumat has given steroids. AKT question. Yes, ma'am. If the inflammation was fine, a short course of steroid is no harm. Giving steroid is not the problem. When to give it, how much to give it, and when to stop is the art. So that will depend on, so every rheumatologist will be different, ma'am. Some gives more steroids, some give less steroids. I am the one who explains the patients more. I'm not sure, then I will give them NSAIDs. If I'm giving steroids, I will explain it to relative, I will explain it to the patient, and then slowly taper it off and see what's happening. But I will investigate everything. I think we have finished with the questions. Thank you, Vinny ma'am, for being an active participant. Thank you for all the clinicians for being such great listeners. Vinay sir, abhi aur kuch? Vijay sir.
It was an excellent session. We have just experienced how Dr. Nilesh Nolka sir has mastered the art of making a complex subject in a very simple way. We have seen theory as well as practical application in rheumatology. No doubt we have heard it, and this complex subject is itself in complex to make it simple, and we have seen it how simplified it has been done. Okay, so we thank you for a valuable time for navigating us through this journey of excellent talk which we have given on a very important subject of lupus, and very simplified way. In fact, it has been you have educated us. What is really touching for me is one case which we discussed about an 18-year-old female lost her life. Okay, that itself, in fact, a situation where it is important to educate the general people also on rheumatism, in fact, because we have seen a lot of people generally waste time. The time of diagnosis is lost most of the times, and they go here and there and don't treat the right doctor to
I'll just
manage
like to
this
interrupt
diagnosis.
Mr. Vijay. When we are
Yeah,
coming to losing lives, I'll just give you a statistic. Though I have lost in rheumat, you don't lose patients very commonly due to rheumatic diseases, because rheumatic diseases are usually not life-threatening by sheer numbers. I've lost
absolutely.
6 patients last year. All
Okay.
6 were lupus.
Mm-hmm.
At least 5 of them presented at least 4 to 5 months later, and all 5 of them had significant clues on their blood test to say that it is lupus. So, and uh,
Oh,
there
okay.
were MD physicians involved, there were GPs involved, and all 6 patients were below 30.
Oh, that's a
And,
very young age to go. Yeah,
yeah, and
understand, sir.
3 were below 20. So it is
Oh, ho, ho.
very, very disheartening to see this kind of picture. And that is why I'm very
Absolutely.
passionate about educating on
This
PTDs.
on this subject itself. That makes us understand why you selected this topic. I really appreciate your concern, sir. And definitely, as you rightly mentioned, it's very important timely diagnosis and managing it properly. We thank you all the audiences to really give up the first Sunday. And in fact, I'm really pleased to announce that this event has been participated by more than 600 doctors, sir.
Thank you.
So we have another 40 people in this group itself on this platform of Zoom link. And apart from it, has been live streaming was going on where we had more than 600 audience listening to this excellent presentation. And I would say eye opener in various aspects of diagnosis and as well as in brief, which you talked about management. So I thank you, sir,
I
for
like to
this.
thank you guys for providing the platform. As usual, a pleasure, sir.
So we as I mentioned that we like to work on all such academic platforms. We have been doing it consistently. I thank my IT team also, where all their Sundays for next 6 months, in fact for next 1 year, all their Sundays are
I
booked.
think
Yes,
you guys have the toughest jobs actually. Okay.
yes, sir. Yeah, Saidam. So we'll officially call of this webinar comes to an end, and any questions can be posted. We'll be also providing links of this recorded video on the YouTube link. So thank you, everybody. Thank you
Thank
for
you.
joining. See you all.
Thank you.
Thank you,
Thank
sir.
you.